Good afternoon, everyone. Thank you so much for coming today. My name is Sabrina Talukder. I am the director of the Women's Initiative at the Center for American Progress. And we're here today to discuss some extremely difficult, frustrating, and heart-wrenching issues that have come up in Idaho versus United States, a Supreme Court case with oral arguments scheduled for April 24th. The legal question in this case is about a direct conflict. Specifically, whether the requirements of the Emergency Medical Treatment and Labor Act, EMTALA, preempt or override conflicting requirements in Idaho's near total abortion ban. However, what we need to focus on is the heart of this case, which is about medical providers, vulnerable pregnant women, and the future of medical emergency care in post-Dobbs America. And there are few people better positioned to discuss the far-reaching consequences of Idaho versus United States than Representative Ilana Rubel, who has been front and center in the fight for women's health in Idaho. I'm really excited because she's not afraid to call out the dire realities pregnant women are forced to endure in Idaho because of the state's ban. And without further ado, I turn it over to Representative Rubel for the opening remarks. Thank you.
Thank you so much for that kind introduction. Yes, I have unfortunately been on the front row seat of an unfolding horror show on women's reproductive rights in Idaho. I was there when this bill, when the ban was passed back in 2020, when we all hoped it would never become a reality. But I thought it might be helpful to provide a little bit of history of how we got here. So of course, you know, there is what I call the anti-choice industrial complex, which is this elaborate web involving a lot of fundraising of groups who have for a long time been activists and raising lots of money on their claim that they were going to ban all abortion anywhere. And they would try initially to nibble around the edges and try to bring trap laws and various restrictions, making it harder. But of course, you could never fundraise off of last year's abortion ban. So they kept becoming more and more aggressive until in 2020. Now, remember, this is still when Roe was on the books, but they brought this trigger ban to say, basically, if and when Roe is ever overturned, then immediately this abortion ban will go on the books without any further legislative action needing to be taken. Now, many of my Republican colleagues who voted for it, and in fact sponsored that trigger ban back in 2020, have said, one of them famously to the New York Times, "We never thought this law would really take effect." They said they thought Roe was going to be on the books forever, and this was just a great way to shake their fist at the Supreme Court and, you know, raise money, win their closed Republican primaries, and show how marvelously pro-life they were or whatever, without ever actually having to face the repercussions of this bill becoming law. Really actually going into effect. Well, lo and behold, we all know what happened when Dobbs hit in 2022. All of a sudden, they were the dogs that caught the car. And this incredibly draconian law that they passed, I believe mostly to satisfy donors and extremists in their base, all of a sudden became the law of Idaho. And even for abortion banning states, this is a very extreme ban. This is not a 6-week ban. This is not a 12-week ban. This is a total ban from the moment of conception. It has absolutely no health exceptions. It has an extremely narrow life exception where basically abortion is only permitted if death is otherwise certain. But if you're facing paralysis, loss of limbs, loss of body organs, permanent bodily dysfunction or disability, none of that will qualify for an abortion. Another aspect is there's no fetal non-viability provision. So if you're carrying a fetus that has no skull, no brain, no nervous system, no possibility of surviving once it's born, you are nevertheless required under Idaho law to carry to 9 months. And actually, Idaho is unique in that we also have a law on the books banning, quote, abortion trafficking, where you can't transport a minor to another state where abortion is legal. So Idaho's law is incredibly extreme. Again, I believe crafted with the idea that it was never going to become law. However, we're now 2 years into this, and the legislature has had ample opportunity to scale it back, and they have had no interest in doing so. We have seen the havoc that this ban has brought. It was almost instantaneous and has only gotten worse over time. So during the almost 2 years since this law went into effect, we've seen the loss of nearly 1/4 of our OBGYNs in the state. We've lost 55% of our high-risk maternity specialists, those fetal maternity specialists who focus on the high-risk cases. An issue near and dear to my heart because I had one of those people that saved my son who would have been born brain dead, but for having those those specialists available. And now he's a straight A student taking AP physics as a 9th grader. So it's not just women that they're going to torment with this, but also babies who are not going to have access to this specialty. We've had 3 maternity wards shut down. There are now parts of our state where you have to travel 168 miles to get to an OBGYN. That is not to get to an abortion. That's just to get to an OBGYN who can check you out and tell you if you're healthy. It has been such a catastrophe, even just beyond the impact on our medical profession. We've seen a drop of over 50% in applicants for OBGYNs to come to the state. We've seen a drop in applicants across all healthcare areas. But even outside of the medical profession, anecdotally, almost every day I talk to people who say, oh, my daughter would love to come back to Idaho, but she can't because she doesn't think it's safe to be a woman of childbearing age in Idaho. I talk to people whose daughters and granddaughters are leaving the state or deciding not to come here because of the dire risk to health that this causes. Now, we briefly had a bit of a lifeline when it became clear that they had really overshot the mark and implemented this ban that has no exception for health whatsoever. The Justice Department came to the rescue and they brought this lawsuit saying, hey, wait a minute, EMTALA, the Emergency Treatment and Labor Act, which has been federal law since 1986, signed into law by Ronald Reagan, which gives you an idea how far we've gone, that Idaho's GOP is now attacking one of Ronald Reagan's signature laws. But the Federal Department of Justice came in and said, hey, EMTALA requires that if you are in an emergency room that receives federal funds, which is basically all major hospital emergency rooms, they have to give you emergency stabilizing treatment. And if that recommended treatment is an abortion, if that is what is required to stop you from hemorrhaging or to prevent dire health consequences, then that's what they have to do under federal law, which under the Supremacy Clause overrides Idaho law. So they said basically, and I think legally accurately, that federal law controls you have to at least get an abortion when it is the required emergency treatment and you're in an emergency center. Now, stunningly, you would have thought that these folks who had initially passed the trigger law and who have openly admitted, whoops, we went too far, we never thought this law was really going to go into effect, you would think that they would be ecstatic that the court had come in, the court, and a court did grant an injunction as soon as the DOJ brought this suit. So you would think they would think, oh, great, they saved us from ourselves. They put in at least this little exception for medical emergencies so that we don't have to see the very worst consequences of the law's failure to create a health exception. But stunningly, that is not how they responded. Instead, they set up not 1, but 2 legal teams to challenge this injunction. So not only did the Attorney General challenge it, but our legislature said, oh, we're going to appropriate an extra $4 million to hire a separate set of attorneys just for the legislature to back up the first team of attorneys, to make sure that no matter what the medical emergency is, no woman in Idaho can get an abortion. And that is literally the only thing being litigated here. This is not about overturning Idaho's abortion ban generally. This is just that tiny carve out where a woman is facing a medical emergency in an emergency room. And this is what they have litigated to the hilt. And tragically, recently, they got we had this injunction, so at least it was on hold while it made its way through the Supreme Court. The Ninth Circuit upheld that injunction. So there was at least a little bit of a lifeline for women in Idaho who could still access emergency abortions under this court injunction. Well, they took it to the Supreme Court. The Supreme Court overrode the Ninth Circuit's injunction and said, we're going to let that law go into effect immediately. So no emergency abortions, does not matter if you're facing paralysis, organ loss, permanent infertility, no matter what, you cannot have an abortion in Idaho. And this case is going to oral argument next Wednesday, where I will be present on the steps of the Supreme Court, hoping and praying that the Supreme Court shows a little bit more compassion and sympathy toward women's health and lives than it has thus far. But again, this is our only near-term hope for a lifeline for Idaho women. Despite Dobbs having gone into effect in 2022, our legislature has now had 2 full years, effectively, 2 full legislative sessions to see the unfolding medical catastrophe in our state, to see the loss of medical expertise that it took us decades to accumulate. And I can tell you, I'm the ranking Democrat on the Health and Welfare Committee. It has taken probably 25 years to draw the number of OBGYNs into Idaho that they managed to scare off in a single year. And it will take us decades more to replenish that. But first, we got to stop digging the hole deeper. But the only hope, we're now out of session. The gavel fell. The legislature is done for the year. No bill was brought to add a women's health exception this year. No bill was brought in the 2023 session. Literally, the only thing they've done on abortion is to appropriate $4 million to litigate against a health exception and to pass a bill making it a felony to transport a minor out of state. So our legislature is moving very much in the opposite direction of caring for women's health on this. So right now, unless something miraculous happens in the election, there is no reproductive rights ballot initiative on the ballot in Idaho this November. So the soonest we would be able to get anything on that front is 2026. I am concerned that by the time the legislature comes back in 2025, we will have lost another 50% of our OBGYNs. Women will be dying. Women are currently having to be airlifted out of the state of Idaho if they have medical emergencies requiring an abortion. Doctors simply cannot proceed with it because they face 5 years in prison and permanent loss of their medical certificate if someone determines that they performed an abortion when death was not certain. And frankly, this is why doctors want to leave. They don't want to have to be put in a position where they have to choose between committing overt medical malpractice and sitting there inactive while a woman hemorrhages out, while a woman loses her uterus or loses her capabilities physically. And they don't want to have to choose between that and prison time. And that is where Idaho law has put them. So we have an opportunity, if all goes well in front of the Supreme Court next Wednesday, to at least get this very thin sliver of a lifeline back, where at least women in medical emergencies in an emergency room will be able to access abortion if we prevail. That's a very big if. And I'm very concerned because the Supreme Court's overturning of the injunction of this law is not a great boding for how it's going to go for us, but we shall see. I want to stay optimistic. But at the end of the day, even if all went well and we won the EMTALA suit, it really would not solve our problem in any meaningful way. And it would help certainly for emergencies to be able to have that treatment, but it would not be a health exception in non-emergency room. It would not help in clinical scenarios. It would not help women who have non-viable fetuses. Women would continue to be forced to go to all 9 months with a completely non-viable fetus that has no chance of survival. There would still be problems, but it would be a big improvement if at least that EMTALA exception were upheld. But at the end of the day, I think to get to truly meaningful resolution of the dire circumstance that women and healthcare providers are in Idaho, sadly, it has to be done, I believe, at the ballot box. Now, I disagree with this profoundly. I don't think it should have to be resolved at the ballot box. I think that Roe v. Wade got it right. And I think for 50 years, that was and should be forever the law of the land. I think we fought a civil war so that people don't have to depend on state-by-state legislatures as to whether their fundamental rights are upheld. I believe this should be something that bodily autonomy is something every woman coast to coast should enjoy. It is not something they should have to lobby their state legislature for. But unfortunately, that is where we are right now. And so I will certainly be working my darndest at the ballot box to try to get this dealt with legislatively, but I do not think that is the appropriate place to be dealt with. I think this is a constitutional right that every woman coast to coast should just have. I don't think our core rights should be up for a plebiscite, and I don't think it should be up to the whims of particular state legislatures. But until something happens at the Supreme Court and or federal level, this is where we find ourselves, and we will have to play with the pieces that we've been given. But I am so appreciative to the Center for American Progress and for everybody that is helping to elevate this issue, because if we are going to win at the ballot box, awareness is the first step. Nobody who knows what's going on is happy about it. They have done polls in Idaho. I think they found that 85% of people believe there should be a health exception at least. And actually a slim majority just believe that women should have a right to abortion. So the laws that we're getting from our legislature do not reflect the public will, even in a deep red state like Idaho. But it's incredibly difficult to change that ship because incumbency is powerful. Closed primaries are a powerful impact. So it's not necessarily the electorate's decision at large that prevails, but often it can be a very slim, very partisan majority whose preference prevails. But again, we will have to play on a tilted field, and we will fight till we win on that tilted field. But it sure would help if in the meantime, there are women who don't have the luxury of waiting till the next election. There are women whose airlift out of Idaho may not get them to a neighboring state in time. And it's likely that lives are going to be lost in the meantime. And again, precious and often irreplaceable medical expertise will be lost in the meantime. So even getting a temporary lifeline from the Supreme Court in terms of a favorable ruling on the EMTALA case will be very helpful. But in the long run, I think we have to look to the ballot box until we can get ourselves a Supreme Court that will enshrine our fundamental rights into the Constitution once again. And with that, I've probably gone on too long. I don't know if there's an opportunity for questions in this, but this has really been the cause of my life for several years, and I'm happy to answer anything on or offline in terms of Idaho's impact. And again, these things start in Idaho, but they spill over to everywhere in America. So it's critically important that we get this right with respect to Idaho's law, because all of America will have to live under this precedent.
Thank you so much, Representative Rubel, for fighting your darndest and for fighting till you win on that tilted field. And I think for me, thank you so much for sharing your personal story about your son. I think one of the most effective policy tools that we can all use is sharing our stories. And there will be questions and answers. Please go ahead and drop your question into the box. And again, we are so grateful for your work. And I'll see you next week at the Supreme Court. We'll be there together. And I mean, I feel really great now after those opening remarks, and it is my pleasure to channel that energy and introduce you to our esteemed panelists. The first is Professor Sarah Rosenbaum, Professor Emerita of Health and Policy and a founding chair of the Department of Health Policy at the Milken Institute School of Public Health at George Washington University. Next, we have Dr. Polly Wiltz, a second-year emergency medicine resident who works in an emergency department in a community-based hospital in East Cleveland, Ohio, where the vast majority of her patient population is uninsured and lives below the poverty line. And we have Dr. Rory Cole, a fourth-year medical student who is born and raised in Idaho, who made the intentional but difficult decision to do her residency in family medicine under Idaho's near total abortion ban. Thank you all so much for coming. My first question is for Professor Rosenbaum. You are the preeminent EMTALA scholar in the country, and we are so honored to have you with us today. You not only played a critical role in the original passing of EMTALA in the 1980s, but have written about EMTALA from a constitutional and public health policy perspective for over 30 years. Can you please explain why EMTALA was passed and why pregnant women in particular are discussed so much in the congressional testimony?
Of course, and let me thank CAP for doing this important session and just add my voice to what a wonderful panel this is and how wonderful it was to hear from Representative Rubel. And I would be remiss if I didn't also note that the decision in Dobbs came down on June 24th, 2022 at 10:02, and at 10:04 I called my daughter, who was a woman childbearing age, and explained to her that all of her friends who lived in the following X number of states should not get pregnant if they were in those states, that it would not be safe to be pregnant, it would not be safe to attempt to carry a pregnancy to term. If there were any problems, they would be turned away from a hospital emergency department. So in other words, it was very evident from the moment that the decision came down that we would be at this place where we are today, where there was just a total fundamental clash between what the states who have enacted these terrible bans thought they had license to do, and this very unique American law. This is a law unlike any other law. It guarantees something that Americans don't generally have a guarantee of, which is access to health care. It is a very narrow law, but it is extremely powerful. And it is what legal scholars call preemptive, meaning that what Congress has done has been to set up a narrow force field around hospital emergency departments, and has said, if you hospital want to be a Medicare participating hospital and you run an emergency department, then you must do these things as a condition of participation. And those things are screening people who come to the hospital who believe they have an emergency. And if the emergency is in fact documented using the standard procedures available to the hospital in its emergency department, then the hospital either has to stabilize the case or has to undertake what's known as a medically appropriate transfer, which is the kind of transfer where a doctor says this person should be moved, there's a receiving hospital, and from a medical judgment perspective, a transfer is better than trying to stabilize in a smaller, less well-equipped hospital. So it is a statute that is absolute, and it is driven by medical judgment, and it essentially cordons off a very specific area of healthcare and says federal government is in charge on this one. And it's unusual because generally, of course, as the majority told us in the Dobbs decision, states get to regulate healthcare. So this is really an unusual American law, but there it is. It is the American law. And the implications, of course, for pregnant women, I mean, I don't need to dwell on it any more than the Representative Rubel has already dwelled on it. And of course, as our two physicians are encountering firsthand. And I would note that that while the focus has been on pregnancy related emergencies, I think it's important to point out two other things. One is that pregnant people are frequent users of an emergency department. About 1 in 500 pregnancies goes to an emergency department. And some of them are for pregnancy-related emergencies, the kinds of emergencies that Representative Rubel described, the kinds of emergencies that Doctors Cole and Wiltz will describe. But the other kind of an emergency is a non-pregnancy emergency, an appendicitis, a car accident, a fall. Many things that can land anybody in the emergency department, and particularly pregnant people, because their doctors don't want to take any chances. They say, go to the emergency department, we want you seen right away. And what Idaho has done has been to make pregnant people radioactive generally, because it is a sad but true fact that you can have a medical emergency that may have nothing to do with pregnancy, but in treating that emergency, there is going to be a consequence, and the consequence may be the loss of a pregnancy, particularly if somebody has to undergo anesthesia or something that disturbs the pregnancy. And all of a sudden, anybody who's pregnant who walks into an emergency department is a potential abortion, either an intentionally done abortion or a byproduct termination of a pregnancy as a byproduct of other treatments. So that's number one. Number two, if Idaho is allowed to do what it wants to do, then essentially that is green lighting states to go after EMTALA for any disfavored population or treatment or condition, whether it is barring all but terminal emergency care for people with HIV/AIDS, whether it is barring all emergency care but death standard care for people who've been in auto accidents on the grounds that somehow having access to an emergency department encourages unsafe driving. I mean, the list goes on and on and on. It allows legislatures like what Idaho has done to essentially impose morals codes on emergency medicine. And that is so grossly far from not only the purpose of EMTALA, but the text of EMTALA, that the downstream effects of not doing the right thing here, of the court not realizing that this is a very, very narrow exception to its holding, are almost incalculable.
Thank you so much for providing that perspective and overview, Professor Rosenbaum. We are, again, so lucky to have you here today. And you brought up all the ways in which a pregnant woman may end up in the emergency department for so many reasons that may require abortion care, but they come in for so many other things. And I would like to ask our emergency medicine resident, the expert, Dr. Polly Wiltz, can you please explain the importance of EMTALA in your day-to-day work and for your patient population, which you have told me that you have many patients that you see who are pregnant early on and who are uninsured?
Yeah, absolutely. First, thank you again for having me and allowing me to be a part of this incredibly important discussion. So I'm in my second year of training in an emergency department. For some context, I work in a very busy level 1 trauma center. And as Sabrina mentioned, we care for the population of East Cleveland, which is predominantly dependent on Medicaid and Medicare. There's a large portion of my patient population that is uninsured. And so as an emergency medicine physician, EMTALA is something that touches on my job day in and day out. There is not a day where I am not thinking about how EMTALA will affect the care of my patient, especially if they are somebody who cannot afford to pay for medically stabilizing care. That's the whole reason we have EMTALA, is to protect patients from being discharged without receiving the care that they need for whatever their emergency may be. And so interestingly, with the patient population that I take care of, there is a lack of outpatient OB-GYN related care. So regarding pregnancy related complaints, I see first trimester pregnant patients every single day in my shift. I have caught ectopic pregnancies that have ruptured. I have managed patients who are pregnant who require mass transfusion and direct admission to the OR for management of a ruptured ectopic pregnancy, from something as what is medically simple as a miscarriage, but can be devastating for that patient and sometimes requires medical assistance, a medical abortion to facilitate, passing of the products once the pregnancy is lost. So with EMTALA, we are, as emergency physicians, it's our duty to take care of anyone at any time. And as we have seen healthcare struggle in the setting, in the post-COVID setting, as well as in the post-Roe v. Wade setting, we have also become society's safety net. So if a pregnant person comes in after a trauma and the mother or the patient who is pregnant is dead, but we can resuscitate her with a procedure that is called a resuscitative hysterotomy. This is a very rare procedure that we do, and it is reserved only with the intention of trying to bring back life from the mom, is basically performing a bedside cesarean with the hope that we can return enough blood flow through the mother's heart to try to bring her back. In a case where we are seeing Idaho say that abortion or anything relating to, stabilizing treatments surrounding abortion, it's really scary to see how that could affect our patients moving forward. When Roe v. Wade was overturned, I was protected by EMTALA. I have not really had to think too much about how to take care of my patient population because I am legally by law bound to provide medically stabilizing care to any patient in the setting of an emergency, regardless of their ability to pay. And should they decide, the Supreme Court decide that Idaho is appropriate in removing abortion from the protection of EMTALA, I completely agree with what Dr. Rosenbaum said. We are putting ourselves at risk for allowing people who do not have medical training to pick and choose which procedures, which life stabilizing treatments and medications can and cannot be applied in the emergency department, and it's infringing on patient rights. This is taking away a patient's right to life, to liberty, to continue living. It makes me very nervous to see that the EMTALA is currently up for discussion.
Thank you so much, Dr. Wills, for providing just like a hands-on view of what it actually is like to be protected by EMTALA and the really dire reality of if the protections that you're afforded and your patients are afforded under EMTALA are taken away. My next question is for Dr. Rory Cole. My question to you is, if the Supreme Court sides with the Idaho State Legislature, what are some far-reaching consequences that people may not be thinking of? Because you're in a very unique position. You have just completed your medical, congratulations, you've just completed medical school, and also you're about to start your family medicine residency in Idaho, a state that criminalizes and subjects potentially you and others to, as Representative Rubel said, 5 years of prison, of jail time, the potential loss of your license. What are some far-reaching consequences of this case on medical students and on people thinking through where to apply for residency?
Yeah, thank you so much again for having me. I think that this Supreme Court case is, just it's so hard in the sense of physician like recruitment and workforce, like Representative Rubella talked about earlier. And I think that's kind of the first far-reaching consequence that comes to mind. We heard that over half of our high-risk OBs have left the state. That 50% like our OBGYNs jobs, right, we've seen a downturn in applicants for those positions. And I think as a medical student choosing whether or not to stay in Idaho, where to apply to residencies, it's scary to think about, all of these reasons why your career might end before it even starts. I graduate from medical school in May. And to think about all of these positions that we might be in, again, that would cause my career to end before it even starts. It's really just a really terrible place to be in. I think, so that applies to so many different fields of medicine. And I think with EMTALA, if that were to be, if the state of Idaho were to kind of win this case, as like Dr. Wiltz has said, the emergency room has turned it in so many ways into the safety net for medical care. And I'm worried that we would lose even like the recruitment of emergency room physicians, the recruitment of our safety net as well in places like this. And the other big kind of area, I think, of far-reaching consequences is kind of the delay in care that this poses. So when somebody's having an emergency or on the brink of an emergency, we work so hard to prevent that emergency from developing. But if you have to airlift people from Idaho to other states to get the care that they need, that hour, 2 hours in that plane, or, this is the Northwest, if there are storms, that prevent you from getting a plane. So now we have to, put people in an ambulance to go to those places. What happens when now this emergency that you could have prevented, severe like consequences to the mom, now all of a sudden those consequences can be really real. And so I think that delay of care is also something really important to consider.
Thank you so much, Dr. Cole. And I want to touch a bit more on the realities of a delay in care, because this phrase and this reality has come up repeatedly in the litigation of Idaho versus United States, where physicians have provided scores of amicus briefs saying that none of the exceptions in the Idaho state ban really discuss this, that a delay in care for a pregnant woman has profound long-term health consequences that is just different from the question of whether or not their life is at stake. And Dr. Wiltz, I'd love for you to speak on that in your experience. What if the Supreme Court does side with the Idaho State Legislature? What's the reality that you're going to have to wait there for your patient to be on the brink of death? And what does that delay in care mean?
I think that's the scariest thing about all of this, is that delay in care, because if it takes, sometimes it can take hours to transfer a patient, especially in states like in the upper, Northwest, where there's one level 1 trauma center in the state of Washington. They refer to the Northwest as the whammy region because of the lack of resources. And so Washington receives patients from all over the Northwest region. And you have a state that is now saying, well, we're not going to allow this stabilizing procedure to happen, and it can't happen here, but there needs to be a medical intervention. And so this patient needs to be transferred. Just for some context, if we're, for example, talking about a patient who has a threatened ectopic abortion or an ectopic pregnancy that is at risk of rupturing, they're stable until that pregnancy ruptures. And then these women crash incredibly fast. They can get so sick. And what I don't think people realize is one of the places where someone can die from hemorrhaging, from blood loss, is into the pelvis. We worry about it in trauma, and we worry about it in pregnant patients because it's such a difficult area to control bleeding. And I have been in cases where we've had to activate mass transfusion, meaning we are bringing cooler cases of blood and hanging blood and other blood products to try to keep these patients stable until we can transfer them to the OR, where our OB-GYN colleagues can perform the life-saving surgery that woman needs. And I cannot imagine how a patient who has ruptured their ectopic pregnancy can survive that delay in care without active massive transfusion, without that stabilizing surgery, especially if they need to be transferred to another state.
And if I could just add something, Sabrina, the terrible situations that Dr. Wiltz is describing assumes that a receiving hospital will accept the unstable transfer. There are obviously cases where it is so unstable and so unlikely that the patient's going to survive the transfer that the receiving hospital may simply say, no, we'll walk you through things that maybe you can do at your hospital, but it's just not, it's not possible to move this patient, not safely. And so it's really important to remember that for a hospital to transfer an unstable patient, there not only has to be a judgment that the patient would be better off at another hospital, but the other hospital has to agree that this is a medically appropriate transfer. And so some of the assertions that people can be moved, as Dr. Wilson's explaining, it may not be possible medically. And if it's not possible medically, then there are no legal protections for it.
Thank you so much, both of you, for explaining really, again, the reality of what this case means for providers and for patients. And, we engage in storytelling at the Center for American Progress because we believe simply that the people closest to the pain should be able to speak their truth to power. And this question may sound simple, but I really don't think it is. And my question is for the physicians: how does the criminalization of your oath, the criminalization of the work that you have sworn to provide to any patient, how does that make you feel? Rory, why don't you go ahead?
Yeah, I can start. I think on any given day, like that description for me changes so much. Frustration, anger, sometimes hopeless, I think right now. What comes to mind is, that moment, maybe this is a little bit of me selling myself out as an early, pretty early in my career, but that moment in movies and TV when somebody is like realizing that they're being framed for some crime that they haven't done yet. We work so hard to be better for our patients, to know the right thing to do for them, how to make them feel more comfortable, how our words impact them. To be in this situation in which all of a sudden now we're the villains in this, we're just trying to do the best for our patients, that feeling of like, how did I get here? How did I work so hard and end up here? That's, I feel like, what's been really striking to me lately.
I completely agree with everything Dr. Cole has said. I feel like my emotions range depending on what article I'm reading about this case, but I think what is the most upsetting and almost the most not contraindicating, but it just contradicts itself. We are bound by the Hippocratic Oath to do no harm to our patients, to do what's right for them. I am bound by EMTALA to provide the best stabilizing medical care that I can before, allowing a patient to go home. And what is being done in Idaho is going to prevent me from executing either of those things. If anything, it's forcing harm on patients, and it is going to create further healthcare droughts in these regions where these laws could potentially be upheld. And so what is going to happen to patients who need this care? People are resourceful. They will find ways to take care of themselves. But I think the risk that those patients will be putting themselves into to try to find someone who will manage a threatened abortion, that will manage a missed miscarriage where they've become septic because they've developed infection from retained products of conception, because nobody was willing to see them because their physicians are afraid of the legal implications of what could come out of this case. It goes against everything that we signed on for and the oaths that we took when we put on our white coats.
Thank you both so much. I know it's really hard to talk about these things and put words to such complex feelings ranging from anger and profound empathy and realization of what this means for your patients. So I'm very grateful. And we have one more question for our panelists, and it's for our providers again. Given that both of you have practiced in rural states with abortion bans, and that Arizona and Florida are going through a profound change in medical and legal norms on abortion access because of things outside of the control of physicians or political actors that are intervening in their day-to-day lives. My question is first for Dr. Wiltz. Do you have any advice for ER doctors in Arizona and Florida as they navigate a new wave of chaos and confusion? And then Dr. Cole, I have a question for you too.
I think as physicians, we are in a unique position of power to be able to speak our patient stories to our legislators. We have the unique ability to get involved with these discussions. I think by getting out there, by voting, by making sure that you are engaging with your representatives to figure out what work is being done in response to these decisions is vital, because silence is the enemy. We have seen this with Roe versus Wade. Like I think we all sort of just kept our fingers crossed, and this is not to put blame on anybody because we were in uncharted territory, but that is the result of inaction. And if you remain silent as a physician when we are bound to be our patients' advocates in these scenarios, I don't foresee things getting better. I think we have a fight ahead of us, and I encourage every ED physician and every physician that's practicing in the United States to really consider what's going on at a state level and to remain informed, because the people that you vote for are the people that are going to either enact or fight against the legislation that we are seeing pop up against or around the country.
Dr. Wills, thank you so much for your fight on this and for encouraging others to fight as well. It's not easy, and you're doing it so well. And my next question is for Dr. Rory Cole, our very own daughter of Idaho. And again, for people in your position, people who just finished medical school, they're contemplating where to go for the medical residencies. They love their states of Arizona and Florida. Do you have any advice for students on navigating patient care, on navigating the medical training they now may not get if they choose and they make the difficult decision, as you did, to continue their medical training in a state with an abortion ban?
Yeah, I think the maybe the easiest part of this decision, the first piece of advice I think I would give is that it's, when you love a state, when you want to come back to a state, the best thing you can do for that state is to go get the training that you need to be excellent when you come back. And so I think making sure that staying for residency is the right choice, that the programs that you're choosing can continue to give you that education, that training that you need is kind of the first bit of advice. And then I think the second bit is that when you're going through this process and when you're making this challenging decision, that whether you feel like you absolutely cannot stay because the case is that the training programs aren't as good anymore, or because it's too hard, or whether you feel like you have to stay to fight, you want to, that everything, in you is like screaming to be in that place, but people around you are like, why would you do this? Why would you stay? Get out while you can. Or you feel somewhere in between, that all of those things are like so normal, so okay, and that realistically this fight is long. As Dr. Welch said, that there is a fight in front of us. There is time to follow whichever path you choose. And that regardless of kind of where you end up for the next 3 years, if you come back, if you don't, the opportunity to stay and help the people who you care about most in that state will continue to persist. And then I'll just echo what Dr. Welch said, that there is a fight in front of us, that there are people that can help change, and that, if we stay quiet, that this is where we end up. And so just to always continue to get your voice out there to vote for people who can help make better change, I think, for the people in your state that you love is so important.
Thank you all so much for your incredible expertise, for your guidance for myself and others on this call, and for answering the fight that is now unfortunately before us in a way that centers the communities that you serve and centers the values of your profession. It's an incredible honor to hear you speak, and we are so grateful for Professor Rosenbaum's scholarship and for the storytelling expertise that Dr. Wiltz and Dr. Cole have very bravely done. And with that, I would love to turn it over to folks in the audience who I'm sure have incredible questions, much better than my boring ones. The first we have is from Shefali Lufra from the 19th. I believe that Ms. Lufra is interested in learning more about what care looks like right now for Idaho with the EMTALA provision blocked and the implications for doctors and health providers just to stay in that state, and if there are national implications around this. So let's start first with Rory. Rory, what's the trend you're seeing in your program, in your school, amongst your peers that are maybe a little ahead of you, maybe 1 year behind as well? What are the trends you're seeing regarding the criminalization of physicians under Idaho's abortion ban?
So I think, the abortion ban in so many ways has affected people in front of me, people behind me. Unfortunately, part of Idaho's abortion ban is that it prohibits us from using public funds for even training trainees in abortion care in the first place. So it makes it hard for people to even find ways to basically get training in these areas. And so not only is kind of like our workforce right now who is providing care unable to give this care, but we're limiting basically who, how these people can learn, how people like me can learn some often very necessary treatments of medical terminations for pregnancy. And so, I think that's kind of the first general trend, is that there's so many fronts on which we cannot provide care.
Thank you so much, Dr. Cole. And Professor Rosenbaum, I would love to know from your perspective, from the public health perspective, what are the national implications of states with abortion bans just not being anyone's first choice for residency? What does that mean for the country?
Well, I mean, there will be entire swaths of the United States where there's simply not appropriate medical care. There may even be not even inappropriate medical care. I mean, there just will not be medical care. We do a lot of work at GW where I teach, examining the experiences of community health centers, which of course are a nationwide clinic network funded by the federal government that makes healthcare, primary healthcare, accessible for low-income, medically underserved populations, with huge rural practices as well as urban health centers. And right after the Dobbs case was decided, we surveyed health centers and ran a match of health center locations against federal data on physician practice. And essentially, we had health centers, including and particularly those in the Pacific Northwest, in the WWAMI region, that are situated in deserts, what are called obstetrical deserts, basically, meaning that even for their established patients, when they come, they can do nothing for them. They have no backup to call. They have they can't recruit. They certainly cannot recruit clinicians, and they themselves struggle because their clinicians are so overwhelmed by all of the patients of all of the ages that health centers have to serve that they can't, even if they're capable of doing so, they can't provide obstetrical care. It is just an astounding thing to see that even where clinical care is anchored, they can't they can't attract the personnel. They can't recruit the personnel. They can't maintain the personnel. So, you may be getting your child's very good pediatric care there, or your mom may be getting your care there, but it's not as even as if you can turn to that community health center if you should become pregnant.
Wow, thank you both so much for answering that very hard question. Our next question comes from a friend in New Mexico. How does Idaho's abortion ban affect states like New Mexico? And if possible, I would love for Professor Rosenbaum to, again, talk a little bit more about these national implications, and also Representative Rubel, who has joined us again. Thank you.
I can start. Certainly, and New Mexico, of course, is a state that borders states with very serious bans, most recently now Arizona, of course. And all of the evidence suggests that in the states that are border states, the number of abortions, of course, has risen exponentially. I happen to live in Virginia, and with the loss now of Florida as a source of accessible abortion care, I know my colleagues here who do reproductive health care are bracing for what is assumed to be a tremendous increase in abortion services demand, because where else can people go in the South? There is no place left in the South. And so every time a state shuts down, then other states that still have services feel the effect. Now, of course, it's a very long distance from Idaho to New Mexico. So I would assume that the states that are feeling more of the spillover effects would be Washington State, Oregon, states where abortion is legal.
Thank you so much, Professor Rosenbaum. And Representative Rubel, we'd love, of course, your opinion as well.
Yeah, well, Idaho is not the only one that's in this boat. So all across the South, Texas, I don't have a laundry list, but there are a number of states that do not have health exceptions to their abortion law, and where this ruling on EMTALA is going to determine, in not just Idaho, but probably in at least 10 other states, whether women experiencing medical emergencies in those states are able to get necessary care, when an abortion is that necessary stabilizing care. So this, I think that the direct impact of this ruling is going to go far beyond Idaho. It's going to reach every state that has a law like Idaho, which is sadly quite a lot. But I agree completely with what the professor said about the neighboring states. In fact, the ultimate irony, there have been articles, there have been deep dives in the Idaho press in terms of, did Idaho's law actually reduce the number of abortions? It did not, spoiler alert. Basically, the number of abortions in our border areas, in the towns that border Idaho, in Oregon, Montana, Washington, that were performed on Idaho citizens, more than exceeded the number of abortions that were occurring in Idaho before Roe was overturned. So ironically, they're not impacting at all, for lack of a better word, quote, elective abortions or whatever, people that are in a health position where they can actually choose, and go seek an abortion. They are still seeking those abortions. It's more costly. It's more of a headache, but it is doable. Ironically, the people who are the most impacted by this are the people in medical emergencies, are the people who actually want to have a baby and are facing a health crisis. So I don't know if this is what they anticipated, but they have not meaningfully reduced in any way the number of abortions. All they've really done is stick it to women who are hemorrhaging and who are facing health emergencies. And it's true that that our neighboring states have had to amp up their capabilities to deal with it. They've all seen dramatic increases in their patients, and they're having to scale up their staffing. Luckily for them, there are lots of OBGYNs fleeing Idaho, so I guess there's no shortage of workforce for them to call upon. But in terms of women who don't have the luxury of travel, this ruling is going to be very impactful for not just Idaho women.
Thank you both so much. And the next question is from Shayna, who is from Florida. As a mother of a 21-year-old in Florida, how can I prepare her in the event that she becomes pregnant? And I open this up to anyone for advice, lived experience, expertise, etc.
Well, what we're seeing in Idaho is that people are having to make sure that they get whatever special rider they have on their insurance for life flight. that you have to make sure if you are going to have to be airlifted out of state, that your insurance covers that you will have a helicopter to go to Oregon or whatever. So that just as a baseline practical matter, I would do that. The Supreme Court hasn't banned mifepristone yet, and you can still get it by mail. So I would probably advise every woman of childbearing age to try to order some and have some on hand to make sure you have that accessible. But beyond that, take it to the streets. You know, the 21-year-olds can save us from this. At least in Idaho, our turnout levels are dismal. Eligible voters under, I think, the age of 30, like 13% of them vote. So if we had a tsunami of people turning out to vote and take action on this, especially in Florida, where they actually have something on the ballot and they need to clear 60% of the vote, activating those young people, just grab a clipboard and hit the streets and get all your friends registered and voting is really the path out of this. I mean, the others are just Band-Aid solutions.
Yeah, no, as I noted before, my unequivocal recommendation is do not get pregnant. Do not get pregnant. I mean, if you want to be pregnant and have a family, move to a different state, or move, if you're pregnant, relocate to a state where you'll get a proper medical care, because pregnancy is such a risky condition. And you just do not want to be pregnant anywhere where you are not confident that if something goes south in your pregnancy, you will get rapid, good care. And it's not possible in these states. And so I would, strongly counsel the best possible birth control until you're ready to have a child, and then have the child elsewhere.
This feels such such a dystopian conversation, because like the fact that we're even saying like just don't get pregnant is really, really sad. But it is a reality depending on where you live and where you've grown up. But what is frustrating for me is I don't know what advice I can give to people who do not have the resources to relocate, who become unintentionally pregnant because their birth control failed, because of an assault, because of, whatever the reason may be. And I think because of that, it is so, so vital that you use the information that you learned today, to use your voice to elevate these discussions, to tell your friends, to tell your female friends, to tell anybody of reproductive age what is going on, whether it's through your social media, whether it's through discussions or a group chat. I think what has alarmed me the most about the EMTALA discussion from an emergency physician point of view is how few emergency physicians are even talking about it. I think right now, it is the time to be pushing this message forward and making sure that anyone who you think may or may not know what's going on is informed.
Thank you so much. And we have 2 minutes left, and I'd love for Representative Rubel for you to answer this last question, which is, if there is one thing people should keep in mind or remember while following this case next week when both of us are at the Supreme Court, what would that be?
Terrific question. Well, I guess I would go with the old arc of history is long, but it bends toward justice. We are right on this, and I think the public knows we're right on this. There are all kinds of shenanigans people can pull. The political process does not cleanly move toward majority will, and it does not cleanly move toward what is right. And it takes an incredible amount of work to yank on that arc to pull it toward justice. But in the end, I think if we make our case and we do the work, there is a clear path for us to win in the end. That does not mean we should be complacent. We got to work our tails off. But it is not a hopeless situation. Things are very dark right now. But we need to educate the public, and we need to work. And if we do that, we will win, and we will win our rights back and make this safe again for American women.
Thank you all so much for this incredible discussion where you have all been vulnerable with your personal stories, with your fears, with centering the patients in your lives, and for centering the horrific obstacles and the state of abortion access in the United States. And I would love to end on the words that you have all said, that it's time for us to fight in the street, to go there, to sign up, to vote, and to ensure that physicians are included in this fight and that we are grounded in constitutional scholarship. And of course, the Center for American Progress will be there at every step of this. So thank you all so much for your time, your expertise, and the grace that you have brought to this field every day, whether it's on the steps of the Idaho Capitol or in an emergency room. And for Dr. Cole, who's just starting, we can wish her the best as she begins a difficult and also wonderful chapter of her life. Thank you all so much. We really appreciate it.